Thank you for listening to this talk today. I had to talk to primary care physicians or general practitioners about this idea that nasal polyps in particular is not sinusitis in the sense that an infective phenomenon. And I really think that's such an important message to get across when we look at what type of treatments we have today. They're my disclosures, none of which are relevant really for the discussion at hand. There's no doubt that in the sinuses, there are conditions in which discretely either the right maxillary sinus, the left frontal sinus, the sphenoid, just the frontal alone, or just the right maxillary sinus again, or the sphenoid. There are situations in which there are discrete sinuses involved where the rest of the airway is unaffected by inflammation. And in this situation, local anatomical or infective phenomenon may be at play. But this is really not what most people are seeing, and it's certainly in particularly when radiologists report on, oh, someone has sinusitis on their scan, they often refer to images like this, where there's a bit of patchy, diffuse changes in the sinuses. And this, of course, is someone who has an inflammatory disorder. It's not someone who just very fortuitously has multiple anatomical problems on both sides in multiple sinuses all at the one time. This is an inflammatory disorder of the airway. And I really want to talk about this because I do think that there's a lot of disconnect between when patients hear about sinus disease, radiologists speak about it, primary care physicians and ENTs. When ENT surgeons see this pattern of disease, we call it diffuse CRS, and it really underlies an inflammatory disorder. And this was the basis upon which EPOS 2020 was trying to move away from the idea of simple classifications as CRS with and without polyps. The first part of this classification system was simply to say that is the disorder limited to the airway? And that's where we refer to it as primary CRS or secondary. Now, if you've got a dental infection or a tumor in your sinuses and you have sinusitis or sinus dysfunction around the dental infection or tumor, then we call it secondary CRS. That's an example of a localized problem, and secondary CRS can be due to broader conditions like cystic fibrosis. And I don't think anyone really refers to it as sinus disease. You essentially have a dental infection and the sinuses happen to be involved, or you have cystic fibrosis and the sinuses happen to be involved. Primary CRS is where you don't have a problem beyond the airway, it's just your respiratory system involved. And the first level of discussion then is it localized? Is the problem in the sinuses simply part of one part of the sinus cavity only, or is it a diffuse process? And then at the moment, we understand a lot about type 2 disease. And I think it's very important that type 2 disease is eosinophilic rich or type 1 or Th2 disease. So type 2, Th2, eosinophilic disease, these are all the same things. These really reflect the fact that we have other treatments now available for this. It doesn't mean that everything now is either type 2 or not type 2. It's just that we don't have characterizations for the non-type 2 group. So type 2 dominant, meaning that's the main phenomenon we do separate out now as an endotype. And the reason for having this structure is that if you have localized problems in your sinus, meaning it's not involving the broader sinus cavity or even the lower airway, then you really probably need surgery. There's something anatomically happening that surgery is likely to play a prominent role early on in the disease. But when it comes to diffuse conditions, there's really no suggestion that in diffuse disease it's a ventilation problem, a mechanical problem, or even an infective one. It really is an inflammatory disorder of the upper airway. And that's what I'm going to talk about here. So I'm going to talk about the diffuse disease because I think this is where sometimes the message is not clear about what really needs to happen in these patients. And we understand that there's diffuse disease, there's type 2, and we'll talk about this here in a moment because that's the most common, and there is a non-type 2 variant. So type 2 is this disease, and one obvious version is we've classified it as central compartment atopic sinus disease. Now, This is, you could almost say it's almost not a sinus disease, because what CCAD is referring to is that some patients who have inhalant allergy develop this turbinate edema phenomenon, and they get all the central thickening in their airway. And when it gets bad, it looks like this, and they get this sort of central thickening on an endoscopy, and then the central thickening shows up on a CT scan. But it is someone who's allergic who then gets changes that then look like a radiology. I think the black halo sign has been discussed a little bit, but the black halo sign is just this phenomenon that you have to have an allergic nose with this sort of jelly-like edema coming off the central part of the tissues. That's what gives the sort of a classic appearance, where the center part of the nose is thickened and the peripheral part is changed. Now, that's not to say that limited true nasal polyposis or other conditions might give you this look, but it's just a look that's more common when you have CCAD. And so when we talk about CCAD, it really is the allergic patient with classic endoscopic changes, then the radiology, not working backwards from the radiology. And the reason it's important to acknowledge is that because it's not really a sinus disorder. So here's a patient of mine who'd had sinus surgery years ago. He never followed through with his allergy treatment. And 7 years later, his sinus is completely normal. All he's developed here is just persistent jelly-like thickening of the actual turbinate tissues. And of course, he's still highly symptomatic. It's not his sinuses that are the problem. It's just that he has active ongoing inhalant allergy causing his problem. Now, he'd been on nasal sprays, and that's why I think for many patients who develop tissue remodeling of their middle part of their airway or the center part of their airway, they really probably need to go on some sort of disease modifying process like immunotherapy. Many of these patients have been using pharmacotherapy, and whether or not it's a lack of efficacy of the topical therapy or compliance, but the practical side is that these patients have all been given pharmacotherapy already and their disease has progressed. So that's why immunotherapy plays a big role, in my opinion. Now, occasionally you'll hear surgeons absolutely convinced that they cured someone who had CCAD or polyps, or they cured someone of their allergic rhinitis by doing a turbinate surgery. And I like this concept of a Venn diagram. You will find patients who have tissue remodeling and a surgeon. You can imagine these two Venn diagrams, where either it's CCAD, so someone with tissue remodeling of the center part of their nose, or very bad turbinate hypertrophy, just someone who's got bad rhinitis. In this situation, if you have patients, especially in their 30s and 40s, where the natural history or the allergic drive has burnt out, if they meet a surgeon that happens to enjoy turbinate and sinus surgery, you'll end up with a situation where a small group of patients will feel like their surgery's cured them. And the surgeon will believe, over emboldened and empowered, that he's actually or she's been able to cure the person's sinus disease or rhinitis and allergic disease. But the problem here is that it's a false sense of achievement. It's really just been very lucky that you've met a person in which the natural history of their allergic drive has burnt out. And then, of course, the surgeon goes on to operate on the next several patients with active disease, and they realize very quickly that just simply removing the tissue remodeling, which is often still required, just doesn't solve the problem. You've got to manage the underlying process. Now, the next one I'm going to talk about is really where we've had some fantastic additional treatments, and that is in the world of severe eosinophilic or type 2 airway disease. And I guess this is the sort of classic adult onset nasal polyposis. These patients look very different. They've got this very edematous airway. They often have involved asthma, and they've got nothing to do with the CCAD group. They've got this very, very severe polypoid and eosinophilic inflammation coming from their sinus cavity. It's important to acknowledge this group. These are patients who have eosinophilic disease. It's got nothing to do with ventilation or drainage, nor is it in an infective process, and they often have broader inflammation affecting their lower airway, such as asthma. If they don't have it when they present, they usually develop it over time, and especially this is true when it's adult onset disease, because the adult onset nasal polyps in asthma really is not a simple inhalant allergy phenomenon. And they love corticosteroids because it's an inflammatory process, and the type 2 process does respond to corticosteroid. And the big issue for us as surgeons is that this is not a disorder of the center part of the nose or a simple allergy. It's really inflammation through here. And for many of these patients, the only way they can get medicine into their sinus cavity is by taking a tablet. And as much medicine that gets there through the bloodstream, gets to the big toe, the liver, the bones, everywhere in the body. So we do often set patients up then to manage their condition locally. But to do that doesn't involve taking polyps out. It's actually really radically reshaping their sinus cavity and then giving them some sort of corticosteroid irrigation. And this is the world in which we now have biologic agents to help us manage this inflammation. Because despite the best of treatments and the best of surgery and the best topical care and the most compliant patient, there are still patients who don't get a response from topical therapy. Just like there are asthma patients, not all asthmatics respond to inhaled therapy. It's not a failure of the surgeon to manage the condition. There are simply a group of patients in whom have severe disease in which topical therapy just won't control it alone. Now, surgery for the diffuse person then, it's got nothing to do with ventilation or blockage. The reason we do it is to allow topical therapy to prevent mucus plugging, overcome secondary obstructive issues like barotrauma, and reduces all the tissue remodeling and polyp formation that's already formed, and for most patients doesn't resolve with medical treatment alone. Off-label options here is often the way we manage it. There are local corticosteroid sprays, but these don't deliver to the airway very well. And although there's no very set commercial product as an irrigation, they are often made up through using betamethasone, mometasone, or budesonide as solutions that we then use in the nose. And this is the same around the world. Many of these drugs are out of patent, and no one's really interested in reformulating them. And there's extemporaneous compounders around the world who will make up solutions for you. And here in Australia, these are 3 ways in which we commonly make it up. And for many years, this is how we get control of patients who have severe disease: create a cavity and treat it. But the reason we do this is because the degree of the eosinophilia, the degree of how inflamed they are, predicts the recurrence of disease and symptoms. And so the more eosinophilic inflammation that's there, the quicker the symptoms will come back after initial therapy, and therefore maintenance therapy is really important to get these patients under control. So this is from the Japanese study to show that, eosinophilic sinus disease, the severity here predicts recurrence. And this is why we maintain these patients, just like asthmatics, with preventative therapy. But those that failed, we had very few options. But in the last 4 or 5 years, we now have biologic therapies. I put up mepolizumab here because in Australia we have PBS support for sinus disease, but dupilumab, benralizumab, omalizumab, there are several options here, and there are now options other than systemic corticosteroid. Now, you might ask, well, okay, that's type 2. And it's not about whether your disease is mixed or not. It's just what is the dominant thing. And I think if you've got eosinophilic changes in your tissues, then you should treat it as a type 2 disorder. There may be other types of inflammatory change there, but if there's a strong eosinophilic signal amongst other, then we call it type 2. We call it type 2 dominance. And I was in Taiwan recently, and someone said to me, "Oh, well, we've got a lot of mixed disease here." I think that's a misconception about what's going on here. I think the presence of eosinophilic inflammation is what's important. If you see a strong eosinophilic component to your assessment of a patient, then it's a marker that they have an inflammatory disorder. It's not an infective or obstructive phenomenon. And so a little bit, it's like having a salty taste. It's not about, when we talk about being type 2 dominant and having eosinophilic components, it's whether or not it's salty. And you can have food that is salty and sweet and salty and sour, but if it's salty in any way, then it's really a sign here that you've got the salt component. When you look at a biopsy, if there's an eosinophilic component, then we refer to it as type 2. But there are patients in which we don't have any eosinophilic component. And in these patients, we acknowledge that there's a group that don't have a type 2 trait at all. It's not there at all. There's no salt at all. And they behave differently. They don't respond to corticosteroid. They're often older, smokers. There's been some studies to suggest that it happened more in obese, older females. But this is still a world we don't fully understand. And they can look similar in terms of polyps. This is a non-eosinophilic patient who's got polyp. You can see that the secretions are very different. And despite applying the sort of usual big sinus cavity corticosteroid irrigation, this person hasn't done well. There's really no change at all to their condition. And when you look at their disease, there's no eosinophilia in their tissues at all. And these patients, when put on a macrolide antibody, often do very well. And you can see from my structured histopathology report, this is very old, this one here, but look how the pathologist has called it an allergic inflammatory polyp, but then there's no eosinophils. This person is a perfect person to trial macrolide therapy on. Macrolides, responders to macrolide therapy in the airway, whether it be upper or lower airway, generally have low serum and tissue eosinophilia traits. And haven't undergone remodeling. And putting patients on macrolides often, like in this woman here, has had complete resolution of all her disease. Her whole sinus cavity and her lower airways just disappeared on macrolide therapy. And this is this group of patients who do very well on macrolides. Now, when we talk about polyps, even in type 2 disease, nasal polyps, like you can see coming here from the middle turbinate in someone with inhalant allergy, it's just not the problem, and surgeons don't have any problem at removing polyps. So here's polyps that are coming off the turbinates in someone with type 2 disease. And in this person here, they really don't have much in the way of sinus dysfunction, just nasal blockage and rhinitis symptoms. And look, surgeons don't have any problems at removing this tissue remodeling that forms in allergic disease. Look how quick it happens. There's a little in-office polypectomy device, and you can see we can remove it in a heartbeat. That's not the problem. This person needs medical therapy. On the right here, this is our classic nasal polyposis. And often the polyps are much more severe in this situation, the tissue remodeling that forms. And they do appreciate having the polyps removed. But in this person, obviously we need to manage the underlying condition that is driving that polyp formation. So yes, we do surgery. I guess if you have diffuse disease, it's just not a disease about obstruction and ventilation. Antibiotics in their traditional sense don't play a role for people with generally especially type 2 disease. And even when they play a role in someone who has non-type 2 disease, it's really using them in a way for their anti-inflammatory properties. It's not about bacteria. So in conclusion, I think for patients who have diffuse CRS, we have to acknowledge that this is not an infective or ventilation disease. It's not about blockage of the sinuses. And this is really important because it moves both the caring doctor and the patient away from these concepts. It's time to manage it differently. We've got to be very careful about saying that you must treat this medically or surgically. I don't think one treatment alone is what's required here. We should avoid single modality discussions. Surgery, as you saw, it's very easy to remove polypoid remodeling, but it doesn't do anything to the underlying process. And biologics or even immunotherapy are very good at changing the underlying process, but sometimes can't resolve the tissue remodeling that's happened in the nose already. So we have two goals. We want an anti-inflammatory goal, which is whether you can achieve this topically, systemically, or biologics. And then you want to restore mucociliary dysfunction that often involves, creating a simple sinus cavity and removing tissue remodeling. And surgery should be used as a tool to achieve a treatment outcome. Not something that you simply just reserve for patients who have terrible symptoms or complain a lot about symptoms. It has to have a very clear reason as to why you're doing surgery and what it's trying to achieve in someone with diffuse disease. And I just want to say thank you very much again for listening, and for lectures like this and other videos, I'll try to continue to post them as we do on our YouTube channel. Thank you.